Today we are welcoming Professor Farai Nyabadza of the University of Johannesburg. And just by way of some background on the professor, he graduated with his PhD in mathematical modeling of infectious diseases in 2003 from the University of Botswana. And he's currently a professor of applied mathematics at the University of Johannesburg. And his research interests involve the applications of dynamical systems to infectious disease dynamics, substance abuse, and other biological systems. The professor is currently the Deputy Head of Departments of Applied Mathematics at the University of Johannesburg. He has successfully supervised 8 PhD students and over 50 Masters of Science students. He's written 3 books and has a significant number of collaborations globally. He's a member of SAMS, SAMSA, and SMB, and he's also the former president of the Southern African Mathematical Sciences Association. And today he will be presenting a seminar very topically entitled Why Modeling Predictions Differ, the Case of COVID-19 in South Africa. So I'd like to say welcome, Professor, and please do kick off. Thank you for joining us.
All right. So welcome, everybody. This is probably the largest group that I've ever had. Last year when I did a CoE-MaSS presentation at the end of August, I think I had only very few participants, but today there are quite a number of them, which is a very, very good and encouraging thing. So welcome to my talk. Apparently, I'm flanked by a team that I have been working with, and the team is basically Dr. Chirove, Dr. Visaya, and Williams. And of course, I have picked up new members on the team that I've been working with respect to the modeling aspects and the COVID thing in the names of Charis, Ibrahim, and also Chenjirai and all the other guys that are on the team. And to my PhD students and my MSc students, even the undergraduate students that I've seen here, welcome. So today we want to look at why modeling predictions differ. And in particular, we want to focus on the case of the models that have been going on around South Africa. And I think the introducer helped us with of course, with the rules that we need to basically just follow. So let's have a look at what is it that I want to look at. So I will briefly introduce this thing, focus on the objectives, and look at the current models, and then basically I just conclude whatever I want to do. So since the emergence of COVID-19 in China, we have seen a global spread of this particular infection rapidly in many countries. And what we have also seen is that the spread of the virus has been closely linked to international travel initially to other parts of the world. And once many of these countries closed their borders, then the spread has been driven by community transmission. So in most cases, you would have a traveler who would come from an infected region and becomes an index case in a wholly susceptible population. And we actually noticed this in South Africa when we had our first case on the 5th of March. And immediately there were measures that were put into consideration, which included closing schools, these lockdowns and prohibiting unnecessary travels, and some other contingent measures that came later as a result of trying to mitigate the infection. Now, the whole purpose of the lockdown, according to the government, was basically to allow them to actually prepare, have additional beds should they be required, especially when the numbers themselves would increase exponentially, and then the hospitals would be unable to cope. Then the government needed time to actually prepare. And in preparing, they actually realized that there was actually a turn in the change of trajectory. And the red line you are seeing here shows the time when we actually had our lockdown instituted. And by the way, this graph simply represents the cumulative numbers of cases between the 4th of March to the 13th of April. And we realized that, of course, the epidemic changed trajectory soon after the lockdown. But we have actually seen that if you go on to, if you plot the number of new cases currently, you can actually see that we are actually on a new exponential curve in terms of the growth of new cases. So modelers have actually modeled various scenarios, and most of these scenarios have resulted in a possible number, it's a number of possible outcomes. I have sat on the Gauteng provincial government presentations when they were actually presenting their models and their scenarios. In fact, they had 3 scenarios, which was they had the best case scenario and the moderate one and the worst case scenario. And a number of models have actually come up as a result of people trying to contribute to the spread of the trying to contribute to mitigating the spread of the infection. Now we know that models are not a report that are sent back from the future. And in fact, models are constructed of stuff that we know and stuff that we think we actually know. And there is actually a lot of unknown stuff about COVID-19 at the present moment. And this is actually one of those particular things that which we actually need to have some consideration of in this particular case. Right. Okay. Sorry, I was just trying to make myself a little bit audible. You know, when you're presenting from home, there's always this thing that always goes around. So we know that this is basically the reason why coronavirus models have risen, giving variations in possible outcomes. Actually, I'll talk about what I actually heard about some projections or some model that had some projections about the virus. We know that the standard caveat from Sir George Box was that all models are wrong, but some are useful. And on this particular premise, we know that whilst all models can be questioned, we can actually use them. They can actually help us to understand how the world is, assuming, of course, that our assumptions are basically valid and we don't feed bad data into the models, or we simply do not link these models to bad data. Box actually reminds us that mathematics creates a shadow of reality. But when I say a shadow, it basically means the reality itself is actually determined by the angle of where the light is actually coming from. And we know that the universe is much, much more complicated than basically what our models basically suggest. And depending on what model is actually put across there, you definitely expect to see variations in the predictions. So why do then models differ? These are the questions we actually want to answer. And what do the current models on COVID-19 say about the epidemic in South Africa? And what are the effects of the differences in the models in the model predictions? Because each prediction has got an impact, because the predictions themselves are intended for a particular purpose And the purpose basically is to influence policy, to influence the management of the disease, to save lives, and basically to which I heard today on the news was that there was somebody who was on the news today who actually said their model predicts 40,000, between 40,000 and 76,000 deaths in South Africa when the epidemic is over. But when one looks at what the information globally is coming, that usually the death rate is around 2% of the total caseload, then we can definitely calculate that if this is going to be 2% of the caseload, how much then is basically going to be the number of infections? And then we can then ask our questions, will these infections be the, is it exactly what we are actually expecting? I was actually calculating on the 40,000, and I've actually realized that certainly we need to have a cumulative number of about 2 million infections. So the question is, will we have 2 million cumulative infections in the country by the end of this particular epidemic? So we know that there are basically several types of models that we have seen that people have been using. And we know that most of the models that I have seen on the blog are basically mechanistic models, which are your deterministic models. And in some cases, some people have added stochasticity in those particular models. And some of them have basically just been focusing models that have mainly depended on statistical methods in which we simply have to fit in some kind of a line or a curve to the data and basically make some projections. I will then describe each and every one of these models separately. Now, there are many different models at play in this case, and basically the basic one, which I saw, was basically the SEIR model, and I'm sure the SEIR model will be the susceptible, infected, and the recovered, which means basically you're classifying the model into only 3 groups there. And this model actually assumes that once you have the infection, you won't have it again. And the question is, with the emergence of COVID-19 again in China at the present moment, is this model basically a valid model in some case? Because then it actually assumes that people recover with immunity, which is not, which is showing that maybe it might not be the case, but I cannot condemn the model entirely, because there are several things that we may actually need to consider here. So we noted that here that the SEIR model does not account for the potential incubation period of COVID-19. And one of the things that we might have noted is that the data in South Africa is actually released daily, and the daily release of the data it actually then and requires that we include some incubation period in the modeling process. Basically, the most popular one, which we have also used and which I've found many people around the globe using in its different variants or in a variety of forms, is basically the SEIR model, where in trying to incorporate the delay between being susceptible and being infectious, we then have to put in an additional compartment, which is our exposed compartment in this case. So the overriding assumption then has been the data has been released daily, and there's an incubation period of between 3 and 7 days, although there are various on basically the incubation period in this particular case. And then the model assumes they are removed from in terms of causing the infection again. Of course, we know that COVID-19 is a developing disease, and we are not very sure basically what the scientific evidence coming up with respect to the infection is actually also exponential. And even our models, they seem not to be coping with what is coming out at the present moment. I know in the past 2 days, we know that in the UK, dexamethasone is now actually being used to actually treat patients that are in the ICU, and it has proved to be a potent drug. And those kind of things, they actually create problems with respect to the modeling. And then in the end, it will then appear as though the predictions themselves may not be okay, or basically it gives rise to variations in the model predictions. Now, of course, this is a standard SEIR model, which has got, of course, a standard incidence function at this particular point here. But of course, this particular incidence function, many people can create different forms of the incidence function, which as well might actually give rise to different model predictions. Now, we know that when the epidemic started, immigration was actually an important part as far as the spread of COVID-19 was. So initially, before the lockdown and before the banning of international travel, it made sense that immigration actually be considered as an essential part of the modeling process. But once we had community transmissions, then it became actually irrelevant, because then it was actually, then this part here was actually blocked, and we only had this part here at play. So we know that certainly many of the models that we have seen, the variations have come as a result of the different forms of interventions that have actually been included, that were basically being included in the models. Now, I know recently we did a model that included aspects of social distancing. Now, after the encouragement of social distancing, we had then that the use of masks became a mandatory process as we moved into different levels of lockdowns, which meant in the modeling process, there was actually a need for the adjustments of those models to include masks. And we know that there have been a lot of media campaigns that have actually been going around sensitizing people about the disease themselves. And those media campaigns, they were actually put into models in trying to obviously control basically the rate of infection, or reducing the rate of infection. There are also some other control measures, such as isolation, which many would probably thought which have been touted as some important aspects. I know in Cape Town, they've actually created some isolation places where if you have the disease, you can go and get isolated there, and you can move out of that place after you have actually recovered. So the inclusion of all these different measures at different stages in the models can actually give rise to differences in the projections and differences in the estimations in terms of the numbers of infections themselves. So we also know that in some cases, this model has been extended by some other people to include a compartment of people that are actually hospitalized, who can actually then in the process actually recover. So that inclusion of an extra compartment, basically in the real mathematical terms, it's actually an inclusion of a delay in the process of moving from the infectious class to the recovered class in some sense. So that also has an impact of actually influencing our model predictions. The other models that we can actually think of are models that actually came in as a result of new evidence that is coming out, that many of the infections are actually mild, and people can even actually recover even without accessing any hospital. And if I can give you a very good example, my son, who is actually in Cape Town, was actually making a confession that he probably had this particular infection and he recovered from it. And because the place where he is staying, there were some guys that were actually going to pray for some guy, laying hands on an individual who later on tested positive for COVID, and the whole family, after those prayers, became sick. Of course, they didn't go to hospital, but they eventually recovered from the infection. And as a result, there is then need to actually include then a class of people that are sort of like undetected. And in cases where you now have to include screening of people, like I know many of you guys, when you enter campuses or buildings, temperature is actually taken, and when your temperature is high, it's actually one sign that you might actually need to go for some tests. So that kind of screening has also resulted in a greater number of detection in the number of cases. And of course, this kind of model is basically geared towards trying to include that kind of those kind of aspects. So in some cases, like I was telling you, I had an opportunity to listen to the models that were presented by the Gauteng Department of Health. And one of the things that they were actually looking at is they wanted to actually estimate how much of the ICU bed do they need. And they looked at their various case scenarios. And in fact, one of the things they actually had to do was to include a compartment of individuals that actually go into the ICU, of course, with deaths in the hospitals and deaths in the ICU as part of the modeling process. And one, of course, of the debates that has actually been there is of these guys that are symptomatic, are they actually infectious? So then I know there was a recent, presentation by WHO that apparently the asymptomatic people are actually not infectious. Meanwhile, many of us had actually designed models that included people that are symptomatic as infectious, and that in itself had also the propensity of creating differences in the number of estimated cases. So the other aspects that have also been included in the models have actually been issues of confining susceptible or suspected cases. And these are basically people that are simply just but suspected to some extent, whether they've been exposed. I know some models have linked them to this class, but also in some cases, we have also included quarantining of the detected infected individuals, creating a different class of individuals that are actually quarantined who can actually recover, or they can be hospitalized, and so on and so on. So the process that I have actually been detailing out here has actually been starting off with an SEIR model. And as we get more information with respect to the disease, we continue to build in or incorporate those particular things that are coming up, or the new information that is coming up. And the inclusion of the new information itself has now the potential of actually influencing how our projections are and how these estimations of our number of cases are. So as I said earlier on, there are also different variations of this particular model. I've seen some people that are actually saying, you actually have people that actually recover whilst they are not detected, and people that actually recover whilst they are detected. And the recoveries that we are actually noticing, or that are being announced by the government, are basically in this particular class here, but not necessarily this particular class there. So there might be an interesting research question of simply saying, how much of this activity here is actually happening within our population, which has probably the propensity to actually accelerate the epidemic, especially when you have infectious cases that are actually undetected. So if we continue to look at these particular models, for instance, I will just go back one slide up. So if you look at all these transitions here within these particular classes. All these transitions here are modeled by various assumptions. The first or the easiest assumption is basically to assume that the parameters are actually constant. And however, in many cases, we know that some people have included functions. And some of the functions, I know some people have actually looked at playing around with the infection rate and made it a time-dependent infection rate. And if ever you want to include your social distancing, this is where basically you include it. If you want to include your masks, this is where you include it. If you want to include your information campaigns, this is where you would include it. Of course, if you want to include your vaccination, then of course you have to vaccinate the susceptible class so that at least they become either less susceptible. Of course, this is one thing that is still under some development. And of course, for those that want to use mass action, this is probably one of those. So the differences in the functions that we use to model these transitions can also result in differences in our model predictions and model projections. So we know that certainly progression to infectiousness is usually standard and it is known, but of course there are still uncertainties, because this is why we say the values, the rate, once you are exposed, it will take you maybe 3 to 14 days for the disease to actually show up. These variations, they depend also on individuals or on individual responses to the epidemic. Those whose immune system is good, they probably will take longer, and those whose immune system is weak, they'll probably take a shorter time in the process. So question still remains over the issue of the exposed or those that are incubating being infectious, because new evidence continues to crop up each and every day. So we also know that hospitalization rates differ depending on the resources. In some countries or in some settings, it's difficult to get people to hospitals. Some people just don't get hospitalized. The screening and testing itself has actually also had limitations. And I listen to the Minister of Health regularly, and one of the biggest challenges has actually been accessing testing kits. And in some cases, I know in the Eastern Cape, they were actually in short supply. And also there have been questions over the issue of the test results coming back late, and the testing process now being like in the Western Cape, they now have prioritized that for those who have got comorbidities that are known, they will have their test results or their samples tested much quicker than the rest of the population. So the other question has been, how do we estimate the hospital bed requirement parameters in our particular models? So all these differences in terms of the functions and the parameters create basically variability in the model outcomes in themselves. So some of the models that I've talked about, which are basically our forecasting models, are basically they're basically statistical in nature, and basically they involve fitting a line or a curve to data and making some extrapolations or some predictions. And you usually consider patterns or sequences of numbers. And in some cases, you don't usually consider the underlying processes that actually drive these particular patterns. And these models usually yield quantitative projections that policymakers may need in the short term, and they may actually look at resource allocations or even plan some interventions in the process. Now, we also know that several forecasting models, therefore, they also have their limitations in terms of the projections, because the projections are usually much shorter. And yet, for one of the things that I have actually been asked by so many people is, when are we going to have reached the peak? Or when are we going to have this particular infection begin to actually slow down within a population? And that actually needs an understanding of the underlying processes in the modeling framework. So we know that models basically need to be robust. And we know that the bigger the model, the greater the uncertainties. And certainly it also adds to the skewness in the predictions. And the questions the models will answer can also be basically a source of variability. If you're you're only interested in trying to look at the masks, then it means that you might actually overlook some other things. And what you overlook may actually also impact your prediction in terms of the models. Also, the structure of the model. I've only focused on the SEIR model and its variations. And I know there are some people that have actually been using individual-based models where you actually treat each individual as a compartment. So the structure of the model itself actually also differs. And I know there were also others that have been using the SEIR models as patch models, like the situation that is playing around in the Western Cape and the Eastern Cape, that those are two adjacent regions that have got population mobility between the two places. In the disease transmission, you can actually see that whatever is happening in the Western Cape is actually mirroring what is happening in the Eastern Cape when you look at people traveling between the two provinces for funerals and all those other things that are actually allowed in terms of our lockdown levels. So we also need to look at whether the models are tractable or biologically feasible, of which I've seen that many of the models that people have been putting out there, some people don't even check these days whether the model is tractable or is biologically feasible. They just take the model and they just fit it to some computational algorithm and then run out and get outputs. But from a mathematical point of view, it is actually very important to check whether the solutions to your system actually exist, or whether the solutions to the system are basically bounded, or they actually play out nicely as far as that. So many models depend on simulations without necessarily passing through the test of robustness. That can create also variability in our models. So when you look at the modeling constraints, we have actual constraints with respect to our accuracy, basically as a result of the knowledge that we have about the virus, and the biological features of transmission are also hard to measure, and in some cases, they still remain unknown or they're still a subject of investigation. And we know that hospitalization and deaths may also be some more reliable in terms of the data, but they might still underestimate the disease burden within communities. And many of the parameters associated with COVID-19 are still very much poorly understood. And the resulting model outputs, of course, will have uncertainties. Now, these are the questions that we also need to ask about every model result. What is the purpose and the time frame of this model? If ever you create a model, you need to also note that every model has different limitations. And this is one of those things that we have been doing with part of the team that I'm working with, that as researchers, we need to be actually humble enough to actually state what limitations our models have. And also failure to actually say that our models have limitations is in itself lacking a bit of honesty, because we know that models always have some limitations. Now, what are the basic assumptions? Because we know models depend on assumptions. What is being assumed about asymptomatic individuals? What is being assumed about immunity? What are the contact parameters that are being included? Are we including them as time dependent? Are we including them as stochastic parameters in nature? And how is the uncertainty being displayed? Because the reliable modeling predictions will usually include a table of parameter ranges. And we need to check whether these ranges, they make sense. Like if we say between 5 and 17 days, so we need to know that if one is infectious between 5 and 15 days, then we need to know that the rate of infection or the rate of infection or the infectivity lies between 1/15 and 1/5. We need to question all that. If the model is fitted to data, what kind of data is used? How reliable is it? And how has the data been collected? Is it good data in this particular case, or is it bad data? Also, the issues of population density, they also play an important role in terms of model predictions in our case. You know, in many of our informal settlements, population density is actually an issue. apparently somebody was actually asking me these issues of social distancing, that how can I distance myself socially when if I make one step out of my door, I'm already in the street. So we also say there are a few challenges with respect to the modeling of COVID-19. The disease is actually heterogeneous across ages. So maybe age-dependent models would work. And we have also seen some second waves of the disease. And can we actually estimate the proportion of people that are asymptomatic, or do we, can we actually focus their impact if we don't know them? And do experiences in countries with other disease burdens help in our model predictions? One of the things that I have always been questioning is with our other comorbidities in terms of our disease burden, has actually our experiences helped us in managing COVID-19, because we probably had some of these structures in place in terms of how we manage our diseases. We have been managing HIV as a pandemic. So when this pandemic came in, we had some other structures that were already in place, and have these structures actually helped us as well. And some have been questioning the taking up of antiretrovirals as whether it has got some impact on this particular infection. So there are also things that we have also noted, that different disciplines have also been modeling these infections. I know some guys in chemistry, they've been using kinetic theory to actually model how people move even in train stations. I know physics, guys in physics have been using particle collisions to actually model how people move around. And obviously for those in fluid mechanics, they've actually been using fluid flow models to actually look at how the virus flows within actually the air. So these differences also in our field of expertise tend also to introduce variabilities in our predictions. So some also have also looked at, can't we consider multi-scale modeling? Because with the virus happening within the scale of hours and minutes within the body, what then would that affect? I mean, how will that impact the scale at population level, which happens in days, and how will it impact when we have this maybe as a seasonal epidemic that happens yearly? So there are all these things. So do these differences create different projections? And in my argument is basically, yes, they basically do in this particular instance. So guys, thank you so much. You need to understand that many of you had to assume that the person you're listening to knows something that you don't. Thank you so much. I really appreciate it, and thank you for being with me.